Kick off, we want to wish everyone a happy Heart Month, and we've had a red dress day, and we're really focused usually this month on women and heart disease, which needs some focus. And so because of that, we're presenting two women cases. And so let's take off on the first one, which is a lady who's 49-year-old Caucasian female who presented with chest pain. She had pressure-like sensation, walking upstairs, walking fast, relieved by rest. Sounds like pretty classical chest pain. So even though sometimes we're aware of women with heart disease who have atypical presentations, or they do not match the male template. Let's just say that instead of calling them atypical. Let's say they don't match our expectations from research of the male template. So that's why it's so important to pay attention to the symptoms and then move on and do something very diagnostic. So let's look at this first case and see what we can glean from that. And so this lady has hypertension, hyperlipidemia, GERD, hiatal hernia, hemochromatosis. Pooh, welcome to the conference.
Thank you.
Patients had a hysterectomy, renal surgery, aspirin allergy. It's a non-smoker. And so she had a cardiac cath. This was in the days when we went directly to cath. We didn't have a lot of options then. It was a totally occluded LAD prior to any branches with what is a frequent collateral, which is a CONUS branch. Sometimes it is a separate origin. It'll come across the anterior right ventricle and hook up with an LAD branch and then supply the LAD. So it's frequently a collateral. So she has a totally occluded LAD, and it's collateralized by the CONUS branch and normal left ventricular contractility. So that's interesting, and it's a female, age 49. I don't know if your expectations are very high for finding females age 49 who are premenopausal with heart disease. Ooh, is this very common?
No, not in my experience. Especially like women in 60s, 70s.
So we thought we would talk about some of the secrets of a woman's heart as we discuss these two patients today. And here's some information, Pooh, about how many women less than 45 years of age, this lady's 49, 12% of women have coronary plaques. 25% of premenopausal women have carotid plaque. And I'm seeing that. We're doing CIMT on women in the clinic, and we're seeing carotid plaque, and probably that much is not more.
Yeah.
So there's some interesting information about menopause and heart disease. I think menopause being the onset of coronary heart disease in women is a myth. And so I think we should focus on the lifetime risk rather than after menopause. Although heart disease mortality increases with age, it's lower in women than in men. It's been suggested that there's a protective effect of female hormones in women, and that's lost at menopause. I don't think that's true. There's also heart disease in women increases exponentially with age with no acceleration at menopause. There's no break in the curve. In men, there's a rapid increase during young adulthood followed by reduced rates of increase, which explains sex differences. We're just trying to compare them to men, and we think there's a change at menopause, but there isn't. And so here's the curve. And so at what age would you screen women to look for heart disease? In men, it seems to be age 40, frequently sometimes because of premature development of heart disease in members of the family will dip down into the high 30s, or because of suggestive heart disease symptoms will dip down in the high 30s. And then, of course, women, it looks to me like age 45. That would be about 5 years later rather than 10 years later, some in their early 40s. I am a proponent of developing a baseline at age 45. I would like to discuss that sometime in the future. I think EKG, echo, when we get highly sensitive troponin I, That would be very helpful in the United States because people shown in the ER have a 30% positive troponin when you use the very, very highly sensitive. The NT-proBNP elevates in women when they're having a cardiac event as opposed to men. And according to the WISE study, sometimes they don't even have troponin increase. They'll have an NT-proBNP first. Carotid thickness, plaque assessment is very important. Cardiac CT can be very helpful. Screening for abdominal aneurysm if there's a family history. And if there's smoking, screening for a peripheral vascular disease is useful. So let's go back to our patient. So our patient had a totally occluded LAD. Pooh, what do you think about this? Is this an acceptable option in this patient?
We have to see images. How well collateralized is it? I mean, if she's getting sufficient blood supply, she's not symptomatic, then I'd do more of a functional test before doing, or a viability thing before doing a Lima to LAD.
Melody, what do you think? Can you speak, Melody? I don't think Melody can talk with the mic right now. So it was recommended by the patient's physician, that was me, that she basically declined surgery, and it was recommended that basically she start on medical therapy, and she was started on Mevacor, Inderal, Iserdil, and it turned out that apparently that week before her presentation, a patient who was in his 40s came in, had a single LAD, had bypass surgery, and died of a stroke. And so we were very sensitized that week to operating on single LADs, so we didn't do it, even though she had what appears to be chronic stable angina. We did not do surgery at this time at age 49. So in the interim, over the next couple of years, she developed right upper quadrant pain and was found to have gallstones. Gallbladder resection was proposed, but it was said that she's high-risk surgery. She later had a repeat cath. There was no change in her anatomy. So, Pooh, would you bypass her now prior to gallbladder surgery?
Do we know that LAD, I mean, if it's CTO, we need to know if it's viable or not. Would we get any benefit from bypassing it?
She has normal LV contractility, so it appears that the anterior apical is functional. But let's look at some of the stuff. We did propose this. We proposed, we took her to the cardiac cath conference, and everybody said do a Lima to the LAD prior to gallbladder surgery to prevent operative death because of a high operative risk, because 25% of her myocardium was ischemic during testing. And so we didn't do it. Patient and I declined, and the patient had gallbladder surgery without complications. What to do next? What would you suggest at this time, Pooh?
Medical management will obviously continue. PCI to the LAD, not, I guess if she continues to be symptomatic, then medical management, yes, will continue.
We continued medical management on her. We didn't see anything really at the time. And she was chronic stable angina, seemed to be doing quite well. Now was in her 50s. How about surveillance testing? Are you a believer in doing surveillance nuclear scans every couple of years just to see where we are?
Guidelines don't recommend it unless there's a significant change in symptoms or they present with a MI, like non-STEMI or something. Not really, no. We don't do it routinely.
That's correct. About the guidelines, that's not appropriate. Here's a adenosine stress test that she had. Tell me about this EKG.
Let's see. AVR, STs look up, V4, V5, V6, ST depressions. So, I mean, laterally ST depressions, inferiorly there are ST depressions, AVR there's ST elevation, at least it's 2 millimeters above baseline. So it's a significantly, I mean, the EKG portion looks abnormal.
So it looks like a lot of ischemia here, although she has a baseline resting abnormal EKG. All bets may be off because of that, but let's look and see what it said. And basically, she had chest pain and pressure during the test. She got the 2.3 millimeters of ST segment depression, culminated in 2.7 depression in lead 2. Some T-wave changes and ST changes that hung out during recovery. There was an accompanied SPECT scan. This was in the days when we were doing SPECT scanning. Comments, Pooh?
It's a pretty abnormal looking scan. So the anterior wall, I mean, comparing rest to stress, there's definitely moderate ischemia, at least anterior wall involving the apex, then antros inferiorly and antro. I mean, anterior, antro, inferior was involved too. So it's going by this, and if she's symptomatic, then Lima to LAD.
So this is what I call a SPECT scam, and as you can see, there's some apical decreased counts during adenosine, and you can see at rest they seem to fill in, but there's also some breast shadow attenuation, there's also some motion artifact, and so these things are so difficult to interpret. That's why we've abandoned them and we don't do SPECT scamming anymore. So basically looks like LAD and no evidence of right or circumflex, and the ejection fraction did drop from 59 to 51% after the scan. So is it time for her Lima?
We could do a PET or a CT.
Well, let's go look and see what we did do. And positive for ischemia. Actually, she had a cardiac cath this time again, and there's something new was found. Not only does she have the totally occluded LAD, but it looks like there's an osteal right coronary lesion that's a 60% lesion at the origin of the right coronary artery, and we're not sure if that collateral, which is the conus branch, has a separate origin, or if it comes off before the right coronary lesion, or if it comes off after the right coronary lesion. It's really hard to tell. So the collateral may be in jeopardy, and of course the ejection fraction is still well preserved. Pooh, what are we going to do to resolve this issue about this collateral?
CTs are, we could consider.
There we are, a CT. And this is actually taken from a file or a folder, but you can see over here on the right coronary artery, on your right-hand side, you can see this calcific plaque at the origin of the right coronary artery. And then it turned out, and I can't show that here, but it did turn out that the conus branch came off afterwards. So it appears that it is in jeopardy. The blood supply to the collateral is in jeopardy at this time because of the proximal 50% lesion of the right coronary artery and because the conus branch comes off the right after the obstruction. We also had calcium score, which was very high, mostly LAD, but there was some in the circumflex as well and to the right, but no significant disease in those vessels. But they did have calcification. So coronary heart disease is usually a multi-vessel disease, May not be severe stenosis in all vessels, but it's a multi-vessel disease. So this lady didn't just have focal left anterior descending disease with total occlusion. She had 3-vessel coronary artery disease. Cardiac cath conference. Lima to the LAD was recommended because of totally occluded LAD proximally before branching and compromise of the right coronary with a 50% osteal lesion prior to the origin of the conus branch, which collateralizes the entire LAD. Because the collateral was in jeopardy and the right coronary artery occlusion would result in a massive infarct and death. You buy this as a rationale, Pooh?
I mean, depends, but sounds reasonable to me. If it closes, I mean, how would you justify if she comes having an MI? It would be hard if we don't do anything now.
Certainly if it closes, the whole shooting match is over. Patient's cardiology and patient's cardiologist, me, and the patient decided that we would decline bypass. She was started on Ronexa, 500 milligrams BID for chronic stable angina, and it tolerated it well. She continued to have chronic stable angina, as defined in the COURAGE study, and which showed that there was literally no benefit from bypass surgery or angioplasty if patients were stable. She did have your PET scan that you asked for, and so with the PET scan, which can be a lot more specific and can give more exact measurements, she was found to have calcification of the LAD, circumflex, aortic valve, some aortic calcification. She also had the huge anterior apical septal reversible perfusion defect of 25%, which reversed to 2%. I suspect the 2% is just apical thinning, physiological apical thinning, and doesn't represent infarction or doesn't represent ischemia. We had a 50% ejection fraction, which actually behaved physiologically with Lexiscan, where the ejection fraction went up to 65% during stress, which is a normal response, which is kind of interesting, giving that much myocardium at risk. Still had normal wall motion. And so, in conclusion, for this Heart Month, this lady actually just died this week. And the story is, I've been spoofing you a little bit because we've gone over a lifespan on this patient who basically began at age 49 in 1976 when I did her heart catheterization. And we basically fought off the surgeons every decade for 4 decades. And now, at age 89, she died of complications of her hemochromatosis. Her cardiovascular status remained stable, with chronic stable angina for 40 years. She did not undergo any surgical or interventional procedure for her chronic stable angina throughout this time period and lived a very productive life. Any comments, Pooh?
I mean, symptoms, would you usually, any intervention we do either for symptomatic improvement or to increase survival? So how bad electronic stable angina with maximal medical therapy, they're still symptomatic. Would we ever consider doing something invasive or no?
Have you ever seen a patient with a 40-year follow-up?
No. No. I'd have to reach 40 to
This is something we never see in any of our cardiac conferences. We hear what happened a year later or 2 years later or something 6 months later usually, but I don't think you ever see patients with 40-year follow-up. I want you to note every decade the surgeons want to operate on her, and every decade she said no and I said no, and she did fine. 40 years of coming to the clinic and then dying of an unrelated disease.
Right.
Any comments from anyone else? We're now going on to case 2, mystery case 2. We just had to show you a 40-year follow-up on someone. History of present illness. This lady is a 62-year-old lady who presented in November 2006 for cardiac clearance for left mastectomy and radiation therapy. She had a silent anterior apical MI distribution of the LAD 5 years prior. She reported having shortness of breath on exertion because of obesity, denied any chest pain, palpitations, dizziness, orthopnea, P&D, or peripheral edema. Her prior workup was a stress test, which we think was okay, and then a rest and a Denison MyaView SPEC, 2006, when we were still doing SPEC scans. She had a fixed anterior apical septal area of dyskinesis consistent with a whole silent MI involving the LAD distribution, no reversible defects, ejection fraction 41%. She has a history of lots of stuff: hypertension, type 2 diabetes, hyperlipidemia, systolic heart murmur, COPD, left breast cancer, GERD, anemia, fibromyalgia, degenerative joint disease, right hip replacement in the past. She's on lots of medications, allergic to Novocaine, non-smoker, sedentary lifestyle. As a matter of fact, they call the place where she lives, which is under some live oaks with moss hanging down from the trees, they call it Slowpoke Acres. Slowpoke Acres. And so when you call her on the phone messaging machine answers Slowpoke Acres. We're not available now. Physical examination just showed some obesity. What would you do next on this lady, Pooh?
Start off with the EKG, echo.
So she's contemplating what would be considered low-risk surgery, low-risk intervention, that is radiation. Here's her EKG. What do you think?
Let's see, sinus. In 2, 3 areas. There, it looks like she's had an old anterior MI with progression poor. It's kind of cued in the anterior and like anteroseptal area. Other than that, that's about it.
Yeah, so the imagers would say this is an apical MI because the correlation with MRI, the poor R wave progression, the Q waves, QSs, it all correlates with apical MI. People used to call it anterior septal or anterior, but it certainly fits the pattern of what we see at the apex. And so it turns out, ejection fraction 55% on our echo, distal apical septal akinesis, normal valve structure. It looked a little thickening of her aortic valve and some calcification. Normal chamber sizes and borderline LVH because of her hypertension. What to do next? Comments, Pooh?
I mean, risk factor modification. Obviously, I don't know if she's had lipid testing. I know you like that pulse test or CRP to see where they're on the risk curve. And then since that stress test was 2006, and if you're seeing her now, it's been a while, so we need some kind of functional assessment if it's still ischemic or not, or what's going on. So we could. Oh, you cleared.
The patient was cleared as low risk because of the old anterior and proceeded with mastectomy, subsequent radiation to the left breast area and chest. Next visit, she appeared again for cardiac clearance for neck surgery to remove a low-grade thyroid cancer, 2007. No new complaints. Denied any chest pain. No palpitations, no other symptoms. Now we're pre-oping her again a year later. Plans, Pooh? Any more observations, or just go ahead and say she's low risk?
I mean, if her functional capacity is good and it's a low risk surgery, go ahead.
She did have an EKG and echo. No changes from the year before. But when you're doing PET scans, you say, this is really easy. We've got an isotope that's in a can that we paid $42,000 for. It's a generator, strontium generator that generates rubidium, and there's no added cost of any day. You have 42 days running time. So we said, let's take a look. We just send her through there, and it's a 23-minute test and see what stuff looks like. So you do a CT for attenuation correction. PET imaging has some real advantages. It's 511 keV gamma ray that's emitted when a positron meets an electron. Travels a little ways to meet that, which is the positron range, and then is annihilated and gives off two gamma rays 180 degrees apart. And you have a round detector that can detect anything that's happening coincidentally. And then we've got attenuation correction from the CT scan. So this showed a lot of calcium, main left, LAD, circumflex, light calcification of the right coronary, dilated LV at rest and stress because of the ode anterior apical MI, ejection fraction 34%, segmental LV dysfunction. The apex was akinetic, anterior wall hypokinetic, inferior and lateral wall were hypokinetic as well. Fixed apical defect and reversible basilar lateral defect. Something new has cropped up. 25% of the myocardiums had defects. This is like our other patient. But 9% of that was reversible and in the circumflex distribution. This was not seen on the previous spec scan a year before. So now we've got a new reversible defect, about 9% of the myocardium. No change in symptoms. Patient's going on for surgery. She's already taken out the anterior wall at apex. Should we risk this, or should we go check it out with a cath and consider angioplasty? Pooh, what would you do on this one?
I mean, since she just had radiation, that increases her risk too. So she may not have anything a year ago, and now with radiation, osteal circ, like all osteal vessels are more at risk. So, I mean,
it is true that the area of radiation was somewhat in the lateral area because there's some calcifications and there were some linear changes in that area, and so it could very well be the circumflex as involved in the radiation therapy. It's usually a lag time of 10 years, though, and this is sooner than the lag time. And so we decided to do a cath. We had two vessel disease now, chronic occlusion of the LAD, just like our other patient, except this one had the big infarct, and 99% stenosis of the proximal circumflex, 50% mid-level stenosis of the right coronary. Since we're considering surgery and we don't want to put her on Plavix, she had a bare metal stent in the circumflex without any problems at all, opened it up, got good flow, didn't do anything with the right coronary with the 50% lesion. The LAD, of course, we know it's a chronic total occlusion, and we know it's infarcted, especially from the PET scan, which is very useful. So she had her thyroidectomy. She went on a year later to get a GI bleed. During that time, they were going to do some endoscopy, and she basically had some problems with MAC, with the local anesthesia, and so she was intubated. She had a short neck. It was a very difficult intubation, but it was carried out successfully. She also was diagnosed with new cancers. She had a lymphoma, not lymphoma, and some myoclonal gammopathy of unknown significance. And now surgery again. She presented for knee surgery in September 2008. We're doing surgery on this lady every year. 2006, 2007, 2008. No complaints, denied chest pain, feeling good. Here we go again. What do we want to do in anticipation of this surgery? Since a year before we had to do angioplasty.
Is her functional capacity good?
She's doing fine. No new problems. Ah, looks like we did a PET. Well, we had the generator again. We got can with isotopes. It's $42,000. It's just sitting there, and we're doing cases, and so we just fit her in easily. She's a obese lady, but we get these great pictures when you're doing rubidium PET and with CT attenuation correction. So it was so easy to do. It's a 23-minute test. No reversible defect in the lateral wall, so it looks like the stent was open. Oh, silent, fixed apical defect, no change. Good ejection fraction. And so she went to knee surgery. And then the next knee, 2010, she went on left knee, kidney stones, repeat CT scan, no new changes. GI bleed again, 2014. Follow-up. Patient presented with complaints of recent heartburn over the last 2 weeks, denied any chest pain, had some palpitations, dizziness, orthopnea, did not have any of these symptoms. And so this is a new presentation for this lady with some symptoms for the first time. Heartburn. She's never had heartburn before. She doesn't have known GERD. So we were puzzled. Here's her EKG. What do you think about this one, Pooh?
Let's see. I mean, the Darwin progression QS complexes are still there. Some T-wave inversions high laterally, but 2, 3 AVF. Let's see. I mean, not too much changes from the last one.
So it does look a little different. She still has her first degree AV block, maybe a little bit longer. And she's got left axis, criteria for left anterior hemiblock, but then she's still got the 4-hour progression. And she has actually a little bit increase in QRS duration. So maybe she's got left anterior hemiblock on top of her own anterior wall MI, and so you can't see it very well. But we know our anterior wall MI didn't go away, or apical MI didn't go away. So maybe she's got some hemiblock with it, and the first degree like she's had before, but a little longer. And we have an echo that we'll show you. So here's her echocardiogram, which it doesn't move very fast when this is streaming online. There's a 300 millisecond lag, and also it doesn't move very fast. So you can't get the good appreciation of the squeezing of this. You can see the septum, posterior wall, aortic valve, mitral valve, left atrium, aorta, left ventricular contractility. What do you think, Pooh? Would you like to see more? See anything?
Yeah, apical for.
This inferior wall looks a little sluggish here. Can't see the apex from here, but we'll go to a 4-chamber view in a minute so you can see that better. The apex isn't going to tell us anything because we know it's out anyway. But here we go. Heart range. This doesn't look like it's moving very well. She's an obese female. It certainly would be nice to have some contrast, or we could inject echo contrast like Definity in here. But it looks like this is not really moving very well. This looks like it's moving pretty good. This would be the distribution of the area of the previous stent to the circumflex.
Do we have a short axis?
Show you some color. Looks like an attempt at a two-chamber view. Again, the lateral septal basilar area has diminished contractility. Same area as the previous stent, which was a bare metal stent. So apical akinesis consistent with old anterior wall mine, new onset lateral wall hypokinesis. There's some aortic sclerosis without stenosis, some moderate MR, which wouldn't be very surprising because that lateral wall is a papillary muscle that certainly can cause ischemia and mitral regurgitation. And so to continue on with our dialogue, we did propose a Lexiscan MRI to separate out what's ischemic from what's edematous from what's damaged, and the patient became very claustrophobic, started breathing heavily, and basically wanted out of the magnet, which is a frequent problem. We decided that we would do a cardiac cath on her and possibly an angioplasty of the circumflex, and it was scheduled electively, but she had some severe shortness of breath, and 2 days before she's supposed to get her cath at Tampa General, she showed up at St. Joseph's Hospital, a different group of cardiologists, and new workup. She had a CT of her chest, which showed no evidence of pulmonary thromboembolism. Here's her SPEC thallium scan in 2016, looking for ischemia of the apex. There was a rest study and then a late scan for redistribution of the isotope. This is something that we used to do about 15, 16 years ago. It was a poor man's MRI or a poor man's PET scan to try to see if there's a reversible defect involving something, and if there was hibernating myocardium. And this was the best we had then. Sometimes you do it even during a nitroglycerin drip. And so very old technology that's been invoked by a very modern hospital in 2016 rather than to do a PET or an MRI. Any comments about this SPEC thallium scan with rest and redistribution? Pooh?
I mean, with late, so they're 4 hours and 24 hours, or just 4 hours delayed pictures?
Yeah, so usually 24 hours. I think you're familiar with that test.
Right. It's, I mean, if the bottom halves are delayed, then the apex seems to be coming back some in the short axis view, but it's fixed in the horizontal and vertical long axis. So overall, I mean, doesn't look viable.
So it looks like not having any medical records and not getting any and winging it on this patient. There was a thought as to whether the apical anterior septal area of the left ventricle was hibernating or not, and so they did this very poor study in terms of being able to get good results as opposed to a PET or MRI, and basically showed that there was a fixed defect in the apex and it wasn't reversible by thallium scan. I'm not sure how that would compare with MRI in terms of sensitivity and specificity. But the important thing is not that for me. For me, the important thing is that the wall, which is not moving right now, is still very much viable and is taking up all kinds of thallium and looks very good. So it looks like that area could be revascularized if it's favorable, if there's favorable anatomy. That's the area that had the previous bare metal stent. So I like the information I'm getting here. I'm just saying that there's just old infarct and there's no new infarct on this hospital admission. Heart is a little bit dilated. Looks like there's something we could do for this lady. So I like what I see.
I have a question. So the short axis, how the bottom half have the apex lighting up some in the donut view?
So let's look at the short axis, and we've got apex here, apex here, apex, apex. Can you see my marker? Yeah. Okay, good. Apex, apex, and then we get back to the base, and so
towards the base. Okay, got you.
So I don't really see that area. Oh, let's go down here. We look apex, apex, septal, apex, 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 apex. Oh, it looks like it's pretty well out from what I can tell here.
Okay, thank you.
It's just color coding it a different way, and seems to tell us this is pretty much the same kind of stuff. And then she had cardiac catheterization. Okay, Pooh, tell us about the cardiac cath as we play this through. We'll give you more images.
So the LAD is CTO, which we see circ. Let's see. Circ seems to have some.
Give you more images so you can appreciate everything in all the different views. Here's the LAO projection. This is probably the most influential.
Yeah, ileocardium. Let's see. Yeah, that's circ. Like proximally, that stent has instant restenosis. I mean, I don't see the stent outline clearly at all from here.
It looks like big-time bad problem at the bifurcation of the main left, involving perhaps the distal main left where it's tapering, and this area of very little contrast coming through proximally here in the LAD and proximally in the circumflex. So it's like main left or main left equivalent disease. Looks very bad. There's also, if we went back on the nuclear scan, we would see that the anterior lateral wall, which is the area of distribution of the diagonal, is still intact. So there must be a diagonal vessel somewhere around here, and we could go back here to see if we can find that. And there it is. There's a diagonal vessel up there that's still intact, that still has basically uptake of thallium that could be revascularized as well. So this could be revascularized, this could be revascularized, so you'd have to get into the distal LAD, the proximal LAD, the distal main left, and the proximal circ, all that stuff you'd have to stent, and then get back in here and then do a stent in the diagonal vessel. Well, let's see what the right's doing.
Mid-RC.
You can see the vessel extends way over on the side, and this is probably what they described before as that 50% LAD, and you can see that there's just a big area of calcification and stuff that the vessel goes down the whole side of the vessel there in the mid-right coronary. And this is what was described. It sounds like the description from before. There may be some distal vessel out here that has some disease, perhaps you know, some stuff out in the posterior descending. But for the most part, the right is probably as described previously. You can go over here and you can certainly appreciate the calcification in the main left, the calcification in the LAD. circumflex. Everything's got calcium over here. And here's another view of this proximal or mid-right coronary. You can also see some septal perforators are trying to move their way up the LAD. There's also some attempt to fill the LAD around the apex, but we know that muscle's dead from the PET scan. Although we didn't do PET FDG, which would be the most discriminating. This is looking at the distal right circulation. Somehow didn't get the mid-right in the camera field. Let's take a look at the LV-gram. And the LV-gram, not surprisingly, shows the anterior apical area of dysfunction. And it looks like the base is beating better than it did on the echo. A little sluggish in the inferior wall. So this is our problem now. We're in the horns of a dilemma. You know, what are we going to do with this patient now that she's progressed to main left disease, main left equivalent disease, the diagonal is still viable, the OM1 is still viable, the right probably hasn't changed any. Are we going to do bypass surgery? Are we going to do angioplasty? Are we going to do a hybrid procedure? Are we going to do an impella with a bypass to preserve cardiac output? And so she was presented at Tampa General Hospital, first at St. Joe, and the cardiac surgery turned her down, and then angioplasty doctors turned her down. They put a life vest on and sent her home. So then we presented her to Tampa General as a high-risk PTCA, and she was turned down, and they referred her to cardiac surgery, which I turned down because of her radiation. And so then we shopped elsewhere to see if we can find somebody that would do something. We talked about a hybrid procedure, but that's not going to work because she had the radiation over here on this side. And so we're not going to do the LAD. It would have to be a hybrid to the circumflex. That's going to be hard to reach. We could try to come across with a REMA. It's still going to be trouble because of the left radiation. So we're not too happy about trying hybrid surgery in this lady like we did with HH, a patient I presented before. So the hybrid surgery plan that was developed by one group was rescinded by us and rejected by us because of prior left chest radiation. So then we were left with angioplasty, the main left, circumflex, LAD, to get to D1, and then to use an impella to maintain the cardiac output. And so the patient was accepted at Emory University and is traveling there today to go get this procedure. So, do you have any questions about case number 2? So we presented 2 cases of women with heart disease. 2 cases of women with heart disease, both with LAD disease. It's an interesting comparison and contrast. One has a totally occluded LAD, but no damage because of a collateral. The collateral is a conus branch coming off the right. We take this lady and present her. She's 49 in the onset of heart disease, which most people usually don't consider heart disease in women premenopausal. We made a case that menopause has no difference with heart disease, and it's a chronic progressive disease in women, just like it is in men. It's just a slower progression that begins in age 40s, whereas in males it seems to begin more in age 30s. And we're actually proposing some baselines to be established in age 40s in women. And so with that in mind, we found that there's a 12% incidence of coronary plaque in women less than 45 years of age. that might come as a big surprise to you, that 25% of premenopausal women have carotid disease, sometimes in their late 30s, certainly frequently in their early 40s. And so it seems like menopause and heart disease is a myth, and there isn't a sharp break and in the onset of heart disease after menopause. It seems like it's a chronic, stable condition that does not accelerate at menopause. Seems like our focus should be on lifetime risk rather than menopause. We've looked at the curves. We've seen the curve in the male. We've seen the curve in the female. And we're aware that perhaps age 45 is a good time for screening if we have a low-risk, low-radiation procedure. And of course we do. We now have CT scanning that has the radiation exposure it has for a while of 2 mammograms, and mammograms are justified every couple years on women. And actually, if you use model-based iterative reconstruction, MBIR, the radiation drops to that of 2 chest X-ray. So frequently people have chest X-rays, positive PPDs, and so on and so forth. So we don't feel reluctant to do chest X-rays. Looking for tuberculosis, which we don't see much, and so coronary disease, which we see a lot, it seems like we would develop a baseline. This is my proposal for a baseline for women at age 45. And you can see that women do have problems. The lady had chronic stable angina for 40 years. We did a lot of tests on her every couple years, and we fought off the surgeons who wanted to bypass her. And she lived a very productive life, but she did have chronic stable angina. The other lady is less fortunate. She didn't have a collateral, so she took out her apex and anterior wall. She's a little more problematic. Preoperatively, we did an assessment with a PET scan and found that she had a new lesion. She had a bare metal stent. Bare metal stents are taking some risk. She got her surgery and went on after that. She had radiation of the left breast. Makes her problematic for surgery of the chest. And now she's got severe 3-vessel disease at the trifurcation. She's somebody who has chronic recurrent disease, maybe chronic smoldering disease. She certainly seems to have immunoincompetence in that she keeps getting cancers cropping up everywhere. Perhaps that has something to do with her smoldering coronary artery disease that's been very progressive over this period of time, whereas the other lady, comparing and contrasting, went a 40-year period with very, very little change, maybe some proximal right coronary disease with calcification, which didn't look too risky. And so we're interested in what your feelings are about approaching patients, and I wish you and would ask you to email me to tell me if you've been screened. We've screened all of the male doctors on campus here at Memorial Hospital. Everybody's come to me and said, hey, I want a PET, I want a CT scan, I want to know what my anatomy is. We haven't seen any females because of the confusion of women and heart disease. I think we need to better define what that confusion is and why we're not more straightforward in that approach. I think it's always been a concern of radiation. And if radiation is the concern, then we've got the test down, the CT test down to that of 2 chest X-rays. If the concern is, well, nothing happens to menopause, so wait 10 years, that takes you to 60, I don't think that's right. So I would like to put that out as a proposition and be very interested in comments. You can email me at eharrison253@hotmail.com. We will be posting this video, which will be at cardiaccarecritique.com, where the other videos have been posted as well. I would like some consideration and some response about screening women with heart disease, what you all think about that, because we've certainly been, again, much more aggressive in male heart disease. Women present with congestive heart failure much more frequently. Women don't present with heart attacks as much. They do present with sudden death. And I think women and heart disease is a totally different concept in terms of the template for symptoms as well as the natural history. So we'll talk more about this topic. We picked this topic this month because it's Heart Month, because we had a Red Dress Day, and we're actually having honoring our women physicians today at Memorial Hospital with a little presentation about women and heart disease and challenging them in terms of considering some kind of testing to get a baseline for their future. Any comments from anybody?
Yeah, Dr. Harrison, this is Janet, and one of the things that we did recently at our Care Assure meetings, review the new consensus statement about women and heart disease that was published last month. And there's a lot of information there specifically about the differences in heart disease and the amount of, the percentage of women that actually get treatment. My question on this presentation is regarding the screening, and if you do not have symptoms, does typically the insurance provider pay for this kind of screening, or is this an out-of-pocket cost because you might be asymptomatic but have concerns about perhaps familial history or other issues that might feel that you warrant screening?
Thanks for your question. As it turns out, the insurance companies are not interested in preventive, certainly
Right.
not preventive cardiology. And so the onset of symptoms is too late to change the course of disease and to prevent anything. And so it's obvious that this needs to be made affordable for patients out of pocket. It needs to be easy, accessible, low radiation, and affordable. And so the cardiac CT is offered here at Memorial Hospital. Total cost less than $300. The technical cost of the test is $199, and then there's the reading fee. And so that's interesting because what we've done is we've taken the technician out of the formula. And so basically the disc is brought over here to the core laboratory, and we post-process it ourselves. And so it used to be technician time of 45 minutes tied up doing post-processing. So the reason why we're able to offer this at such a low cost and a high value is that we do the post-processing ourselves in our own core laboratory. And so the cost of a one tire for your car, which is car preventive maintenance, you can do preventive maintenance on your heart. And it's basically low radiation procedure with contrast for less than $300.
Right.
The other tests are office tests that can be provided very cheaply. So AB ratio is nothing. Taking a look at the abdominal aorta is nothing. Looking at one carotid for thickness is an easy test. And then the echo to examine the heart to make sure there's nothing that we're missing in terms of valvular heart disease or wall motion abnormalities. And so the echo is helpful because when the cardiac CT, we're not doing the whole CT. We're just doing the coronary angiography. We're not interested in left ventricular function because that's more radiation exposure. And so we're just getting the coronaries. And so this turns out to be a viable function and a viable test that's affordable, accessible, low radiation, low time, done in 10 minutes. Prep.
Right.
Some patients, we put them on GoPro-XL, 100 milligrams. Some patients just come in and we give them our low-pressure IV. And so, it's something that can be provided. We've done this for guys, and we do maybe 6 or 8 of these a day on patients. You might ask, why don't we do the calcium score? And why are we doing this instead of calcium score, which is only $99? And it turns out that the calcium score is much later in the disease. And so you're going to miss stuff with the calcium score. You're going to see later disease that had a chance to become calcified, and you're going to miss the advantages of CT where you can catch the disease earlier. Any other questions? And so we like to do the pulse test, which is an inflammatory marker test, is $175. These are very affordable tests. So we like to do stuff that's affordable, that's available, and we'd like to make this more available throughout the HCA system so that we can screen both men and women with low radiation and manage their disease. And so patients either have no coronary artery disease, then you have a 15-year warranty of not getting coronary artery disease by the research studies. If you have calcific focal plaques, you've got a 1% per year chance of having plaque erosion through the endothelium, which is very low. And then there's mixed kinds of disease that we see. Of course, you know, we're very interested in plaque analysis, reading plaque, and we're interested in following plaque serially to make sure that what we're doing is favorably influencing that plaque. So we have a test called a plaquogram. Single rotation of the gantry makes a picture of the plaque for comparison, and the radiation exposure of that is the same as dental X-ray. Any further questions? We would like to make this testing available throughout HCA, and we're looking at that with the administration of West Florida. We're looking at that, how we could upgrade scanners, how we could go to low radiation procedures, and how we could do this as a more widespread testing to show the value of preventing heart disease by early detection. Well, thank you very much for coming today. A happy Heart Month, and we look forward to seeing you next week.
Thanks a lot. Appreciate it.
Bye, Janet, Christine, Donna, Janet again, Shannon, Sharon, Pooh.